Good evening, everyone. Thank you for your kind introduction. I hope you see my slides. Everything's okay?
Yes, we do.
Okay. So, 10 years ago, we had only ESD as an option for early rectal cancer. So I remind you that ESD was introduced in 2009 in Japan, and now it has been established based on guidelines for the treatment of early colon cancer up to T1SM1. However, new endoscopic procedures have emerged like EID or full thickness resection, and in my presentation, I will introduce you to all these procedures. Let's start with a case. We have a 77-year-old patient with atrial fibrillation presenting with this bulky rectal polyp with MRI findings indicative of T2N1. However, biopsies disclose high-grade dysplasia. From an endoscopic point of view, the chromoendoscopy with a high-definition endoscope showed a JNET 2A, 2B classification. So in this clinical scenario, what are the options? And do the surgeons believe that this lesion can be removed endoscopically? Actually, it can. So after 2.5 hours, this lesion was removed endoscopically. Why did we remove this lesion despite the MRI findings that showed invasion? Because we know, according to studies, that the most sensitive and more specific way to identify the depth of invasion is by studying through endoscopy the vascularity, the vascular pattern, the pit pattern of the lesion. So MRI has a tendency to overstage these lesions. So we have to be very cautious when we interpret and when we analyze a result of an MRI. What are current indications for endoscopic treatments? In other words, which lesions do we remove by ESD? Mainly early colon cancer, early rectal cancer, when it is in situ or when the depth of invasion is up to 1,000 micrometers. So T1SM1. However, the reality is that we never know in advance, before resecting a lesion, the exact staging. A crucial point is to recognize which are the criteria for a curative resection. So anyone who removes lesions at the rectum, surgeon, endoscopist, should know which are the criteria that we have to search and identify when we have a report. Besides the depth of invasion, the grade of differentiation is important, and when the lesion is well or moderately differentiated, it's a good sign. It is crucial to avoid lymphovascular invasion, have a low tumor budding score, and of course have a zero resection. When only the depth of invasion is positive, I mean, when we have a deeper than 1 millimeter depth of invasion, is not anymore a very strict sign of non-curative resection. In other words, we can tolerate it as far as the other parameters are negative. That means that we don't have any lymphovascular invasion, we don't have a high tumor budding score, and the lesion is well differentiated. In this table, you can appreciate that MRI and EUS are not so sensible, neither very specific for the staging of T1, T2 cancers. For that reason, we mainly base our decision on whether we're going to resect endoscopically a lesion based on chromoendoscopy and zoom endoscopy. In this area, we have a weakness. We are not all very well trained to identify the JNET classification or the Kudo classification. And I'm not embarrassed to tell you that I don't feel very confident to predict the depth of submucosal invasion based on chromoendoscopy. However, in the next 5 years, we will have major help from AI. So expect that an AI device will be connected to our endoscope, and we have a very accurate prediction of the depth of invasion. Let's see the next case. This is an 80-year-old patient who had multiple polypectomies in the past. However, the lesion was never completely removed. And at this point, we have a large lesion, but at the center, there is a very suspicious nodule with loss of regular vascularity, indicative of invasive cancer. So, what would you suggest to do for this lesion? Would you remove it endoscopically, or should we send it directly for surgery? For such a patient with comorbidities, I mean, he's 80-year-old, ESD still has a role. ESD should be considered as an histologic procedure. What do I mean with that? I mean that this gives us the opportunity to have a very precise and accurate macrobiopsy. So we can still remove this lesion, analyze the result, check whether all criteria are met, and then we decide whether this patient needs adjuvant treatment. In this case, the lesion was removed unblocked. The resection was R0. However, we had a T1 SM2 depth of invasion. So the depth of invasion was more than 1,000 micrometers. That means that our resection is not curative. However, based on recent guidelines, if we have no lymphovascular invasion, if we have good or moderate differentiation, if the Barton score is good, then we can discuss this case into a multidisciplinary team and eventually do a close follow-up or even do adjuvant therapy, radiotherapy, or chemoradiation therapy. This is acceptable at this moment, especially in old patients. In particular, in this case, this patient was had a close follow-up. He received radiotherapy, and 6 years later, he has no recurrence. However, this is not always the case. I have 2 cases that had recurrence at the follow-up. What is very important to understand are the 4 factors that predict the risk of lymph node metastasis. So the grade of differentiation is very important. When we have a poor grade of differentiation, the risk of lymph nodes metastasis is 20%. When we have lymphovascular invasion, the risk of lymph node metastasis is up to 40%, pretty high. And when we have a high tumor burden score, the risk is about 20%. However, if we have only deep submucosal invasion, the risk of lymph node metastasis is even 2%. So we can tolerate a T1 SM2 lesion if all other criteria are negative. And based into our society guidelines of the European Society of Gastrointestinal Endoscopy, we can tolerate a deep invasion when all other criteria are negative, and we can propose to the patient adjuvant chemoradiation therapy. So this is according to our guidelines published in Endoscopy a few years ago. Now, we explained the indication of ESD. Let's see some real examples. This is a big lesion involving significant portion of the rectum and involving also the anal canal. These lesions a few years ago were sent directly to surgery. However, the involvement of the anal canal is not anymore a contraindication for resection. Actually, for someone who does colon ESD, is not at all difficult. However, we have to know that these patients have a significant risk of stricture if more than 180 degrees of the anus are involved. Here is another lesion involving significant portion of the rectum and anal canal. this patient developed stenosis and underwent serial dilations. Here, another ideal case for ESD. In addition, patients that have undergone multiple attempts of polypectomy, but we have still a recurrence, residual tissue, are excellent indications for ESD. Why? Because through ESD, we can remove even the fibrotic tissue unblock. So the presence of fibrosis is not anymore an obstacle for R0 endoscopic resection. The new trend in endoscopic resection is this new technique, which is promoted especially in the Netherlands, and it's called endoscopic intermuscular dissection. The concept of this technique is that when we have fibrosis or when we have suspicion of invasion, we go beyond the submucosal layer and we dissect the transverse layer from the longitudinal layer of the muscularis propria. So in this neglected case of multiple attempts of polypectomy, there is extensive fibrosis everywhere, even at the anal canal. And in this case, we proceed with intermuscular dissection of the anus and of the rectum. In some areas, even full thickness resection may be needed. So, as you can see, we have an additional option, more aggressive option of deep dissection in cases of fibrosis. In addition, we can use this technique as a salvage technique in cases of R1 resection. For example, in this case, we have a net that had been removed by means of EMR. However, the resection was not R0, so by intermuscular dissection, the mucosa, submucosa, and transverse muscular layer were removed and blocked in order to avoid a surgical procedure. What about full thickness resection? So if we have a lesion that is located below, which is located at the distal 2-3 centimeters of the rectum, we can be even more aggressive. For example, here you see a T2 lesion where circumferential incision was done, and what we see at the last image is that we have perirectal fat. This looks pretty scary. And nowadays, in 2026, not only we can do this type of procedures, but at the end we can even close completely the defect. Let's see a few examples. Here we have a recurrent polyp, and at the second image, you can see intermuscular dissection. And in the third picture, you can see an area where in purpose, full thickness resection was done. Why did we do full thickness resection? Is there any risk of infection of peritonitis? No. When we are located at the last 2-3 centimeters of the rectum, there is no risk of such a complication. And when we have the possibility of exact endoscopic assessment with identification of the areas of submucosal invasion, as in pictures 1 and 2, we can be very selective on where and when we're going to perform deep resection. For example, here we have a lesion that was referred for ESD. However, when we evaluate even in white light the lesion, we can clearly identify high-risk features of deep invasion. We don't need chromoendoscopy here to understand that this is cancer. However, if you check the third photo, which is an underwater inspection with zoom magnification, there is a central area where the vascularity has been completely distorted, and this is a JNet 3 pattern. That means deep submucosal invasion. So when you perform ESD for this lesion, what you expect is to identify the invasion, which looks like fibrosis, at the middle of your dissection plane. In that scenario, you can in purpose perform full thickness resection in order to achieve an R0 resection, because if the muscle is invaded with intermuscular dissection, the resection will be R1. So this procedure achieves R0 resection. It's not curative from a scientific point of view, but achieves an exact staging of the lesion. And if the patient is not candidate for surgery due to comorbidities, this procedure can be accepted as a solution for that case. This is an extreme, more aggressive case. This is a lady who's the mother of a surgeon. She's 87, 80, 85 or 87-year old, and she suffers from recurrent rectal bleeding because she takes anticoagulation treatment. She has a small invasive rectal cancer, and the problem of this patient is not the cancer itself, but the bleeding. So in this lady, due to the lack of possibility of surgical treatment, we perform under propofol sedation a full thickness resection of this tumor. It's like TEM or TAMIS, but with endoscopic tools. The steps include identification of the lesion, circumferential incision of the mucosa, of the submucosa, and of the muscle, and then unblock resection up to the level of the perirectal fat. This is the step of circumferential incision. The procedure is done under propofol sedation, and the lesion is located 1 or 2 centimeters above the dentate line. At this moment, we perform the myotomy, and we identify the perirectal fat. Huge vessels are encountered, and they are all coagulated with spray coagulation mode. This is a hot biopsy forceps. So we apply surgical concepts. Now we go underneath the tumor, we dissect the perirectal fat, and this is our final image. So we have done full thickness resection, and we left this defect open. Although nowadays, in 2026, this was done in 2022, in 2026, we can even close it with new tools that have appeared in the last 1 or 2 years. So this was a T2 lesion. The lesion was removed and blocked. The patient received radiotherapy, and look, after 1 month, the area is completely healed. So this patient was treated, her bleeding was treated, definitely. She could eventually have metastasis in the future, but she was 86-year-old. She didn't have the opportunity to undergo a radical surgery. So full thickness resection is an option as a salvage procedure for very, very selected cases. And this is not applied by few centers, but by many centers around the world. And this is a multi-center study where we applied the concept of endoscopic full thickness resection in combination with radiotherapy for very, very selected cases. So in conclusion, in 2026, we have 3 possibilities for the endoscopic treatment of early rectal cancer. If we are located at the distal rectum, we can be very aggressive and we can do even full thickness resection. If we are at the mid-rectum, where there is a certain risk of perforation, we can be limited to ESD or EID, intermuscular dissection, and for the proximal rectum, we can only do ESD. The indications are clearly cancer in situ, cancer with SM1 invasion, and selected cases of SM2 or SM3, when the other risk factors are negative. I mean about lymphovascular invasion, Barring score, and differentiation. Selected cases of T2, for example, in patients with comorbidities or for very old patients, in selected cases, we can be even more aggressive and do full thickness resection, always after multidisciplinary discussion and the consent of the patient and his clear explanation of the risk of lymph node metastasis. The message is that things have changed. We have become more aggressive, but we have to interpret cautiously both the histology, MRI, EUS, all the results, and explain the patient that even if we are not surgeons, we can remove early colon cancer, early rectal cancer. And if we don't meet the curative criteria, the patient will go under close follow-up and the surgeon will intervene if there is in the future recurrence or metastasis. If you're interested in more in this type of procedures, you're welcome to our courses in both Athens and Rotterdam. Thank you very much for your attention.